Okay, so chronic ankle instability, what is it and how does it occur? Okay, so chronic ankle sprains. This is what we see as chronic ankle instability, or a multitude of ankle sprains that occur over time and lead to repeated ankle sprains because of that consistent weakness or instability of that ankle joint, right? So there's a couple major ligaments that are involved with ankle sprains, the ATFL being the weakest and the most susceptible to tearing or rupturing. There are a couple different grades that we look at for ankle sprains, grade 1 to grade 2, grade 3, depending on how sprained those ligaments are, whether it's a complete rupture of the ligament or a slight rupture. But the lateral ligament complex on the outside of the ankle, ATFL, CFL, PTFL, the ATFL is the weakest and most commonly injured of the three. Why it matters is roughly 1 in 5 ankle sprains become chronic instability, and untreated chronic ankle instability raises long-term risk of post-traumatic ankle arthritis. So how does it occur? The mechanism of injury is most sprains come from poor foot positioning at landing. The ground reaction force drives an explosive inversion, the sole rotating inward, and the subtalar joint in about 50 milliseconds faster than you can react. So I'll put a picture up, but it's where that ankle comes in, rolls, and you have no idea how to get it back to its original position before the rolling occurs. About 70 to 85% of ankle sprains are inversion injuries that damage the ATFL and the CFL, right? So that's that of the ankle. The kickboxing angle, with a Muay Thai fighter or any kickboxer, the supporting leg is typically the one that sprains the most, right? It's the supporting leg, not the kicking leg. In elite Taekwondo athletes, significantly more ankle and ligament injuries occurred on the non-dominant side or the planting supporting leg, according to the National Library of Sports Medicine. Foot and ankle injuries in elite Taekwondo athletes, the 4-year descriptive analysis by Maximilian Willenschutz and Johannes Ruther, to name a few. So pivoting on that planting leg during a roundhouse or a teep and landing off balance after kicks, foot contact after a clinch, or aggressive pace and high exertion where that coordination is reduced and fatigue really sets in, the sprain risk climbs when postural stability drops. Each sprain stretches the ligaments and dulls the productive reflex, so the next roll becomes much easier. Some signs and symptoms of this is recurrent rolling or giving way, especially on the plant foot of that kicking, a feeling of looseness, the ankle can't be trusted, or there's a little bit of laxity in that ankle joint during sparring or footwork, right? So pushing off, cutting between, getting outside, inside of that center line, lingering swelling, stiffness, or aching after sessions where there's that chronic, sort of overuse type of feeling, right? Where that overuse injury occurs. So I have a history of multiple ankle sprains on both ankles from soccer to developing my career as a Muay Thai kickboxing athlete. And what I can tell you is that there is a history where the more I sprain one ankle, the easier it is to sprain that ankle in, sparring or any type of activity. Some assessments that a coach or physical therapy will check, which isn't a self-diagnosis, is anterior drawer test and the Talar tilt act test, which is checking the mechanical laxity of the ATFL and the CFL, some prominent ligaments that are involved in those ankle sprains. So another test is weight-bearing lunge test, where you can see the dorsiflexion range of motion being limited after repeated strains. Dynamic balance screens, the STAR exertion balance test, or SEBT, and the Y balance test are the standard functional measures according to Rebuilding Stability, Exploring the Best Rehabilitation Methods for Chronic Ankle Instability by Robert Tedeschi, Vincenzo Ricci, Dominic Tantarino, just to name a few, from this article on National Library of Sports Medicine. It's a PubMed article. And then single leg balance tests are also very helpful, where eyes open versus closed to expose a proprioceptive deficit between the two. So tandem, single leg, right? Those can be very helpful. So in treatment and rehabilitation of chronic ankle instability, the evidence favors functional management, early weight bearing, and bracing combined with therapeutic exercises, reducing the recurrence of the injury and improves the recovery. So for me, this looks like ankle ABCs, inversion, eversion, plantar flexion, and dorsiflexion, maybe an ankle ABCs, where I'm just drawing the ABCs with my ankle initially, and then once I introduce a little bit of mobility back to that joint, I start to load it with a band, right? So I have a band here, right, for eversion, inversion, and then plantar flexion and dorsiflexion, right? So those are just a couple exercises to name a few. And those are all early stage exercises. As soon as possible, once that joint can tolerate a little bit of movement, and you can start to load it again as soon as possible, versus icing initially and delaying the onset of recovery in that joint. According to the NSCA Essentials, the 5th edition, Chapter 23, Rehabilitation, Reconditioning, and Medical Issues, to protect tissue in the acute phase, progressively load to strengthen the ligament and address pain, swelling, mobility, strength, and sensory motor control. The 3 big rehab targets are to restore dorsiflexion range of motion, strengthen the peroneals and everters, right? Or everters, and retain balance and proprioception. This is the biggest evidence base for reverting that chronic ankle instability. And don't forget upstream joints like the knee and hip and their ability to help the ankle out through these different force mechanisms. Some exercise progressions for phase 1, phase 2, phase 3, right? Restore and activate, that's going to be your ankle alphabets, your banded eversion, inversion, isometrics versus isotonic exercises, calf raises, and dorsiflexion mobilization. In the brochure, I show a soleus press, which is a seated dumbbell on the knees exercise. Phase 2 is going to incorporate balance and strength, right? So it's going to be single leg balance, eyes open versus eyes closed on an unstable surface. Single leg RDLs, N-range heel raises. Use N-range heel raises to strengthen the plantar flexors, everters, and inverters. And then there's going to be phase 3, which is more sport specific. So this is going to be introducing that plyometric type of exercise where you're going to be side to side ankle hopping, front to back ankle hopping, and introducing different unstable surfaces into actual sport specific movements, like kicking a heavy bag for Muay Thai kickboxers. Heavy isometrics to build tendon stiffness surrounding that joint is also going to be extremely important. And that's going to be using the Berlin method, which is a specific rest to work ratio that is great for isometrics and building that tendon stiffness. Highly researched. Some return to sport considerations is it's not really calendar based. I look at rehab as a staircase, right? So how far you are along, and progression depends on soft tissue healing, which takes a while and it takes different times for everybody involved. So dynamic postural control is the key predictor. Recovery of it is associated with a returning to sport, pre-injury sport level, while residual pain, recurrent instability, and poor dynamic balance predict failure of return, according to the National Library of Sports Medicine, in an article called The Predictors of Return to Sports Following the Modified Bronston Procedure of Chronic Ankle Instability, which is actually an article by you, Dr. Kim. So I'm sure you know this very well. And then prevention strategies, incorporating balance and proprioceptive training as the headline. Posture control, range of motion, and overall ankle function are going to be key here. So that's going to be assessing different balance exercises, how well you can produce force front to back, side to side in different planes of motion, and building the supportive leg specifically, right? So if, as a Muay Thai athlete, it's my supporting leg, right? So if I typically throw a roundhouse kick with my right leg, making sure that the left leg's stability is incredibly developed and it can handle strength, endurance, and postural stability under fatigue. Risk factors worth screening are previous sprain history, limb dominance, and strength imbalances between eversion and inversion. Bracing is not, I don't think it's that helpful. Like, you shouldn't be relying on a brace, but initially it can be very helpful for return to sport and, practicing different exercises and limiting that range of motion to prevent another sprain on an already unstable joint. But for rehab, after a certain point, you should not be relying on that brace for help. So that is chronic ankle instability. Thank you for watching. I believe that the best way to rehab chronic ankle instability is to, as soon as an ankle sprain occurs, introduce that movement as soon as possible, not relying on ice or braces as much. Maybe in that first 30 days that's possible depending on the grade of the sprain, and then introducing load as soon as possible back to that joint, telling that joint that yes, I do in fact want to use it, and then introducing plyometrics in that middle to later stage of the rehab process, in that front to back ankle, hop, side to side, and then continuous bounds, single leg bounds, exercises like that, to where that ankle is taking a lot of force and it's producing it quickly and effectively, and that stretch reflex is being incorporated well. Thank you.